so let's go ahead and jump in and talk about face-to-face and home health cert and PT certs. There are some discrepancies, this person said, in the office and external billing office with billing certifications signed by the doctors for face-to-face visits for home health, plan of care, and physical, occupational therapy, and hospice. What are the proper HCPCS codes and date that should be on the certification for billing purposes? Well, this is actually, just like it maybe sounds, a mouthful. But what I was able to do is to go in and pull out some specific information that I think is going to be beneficial for you. Different certifications fall under different timelines. For example, hospice. You can usually find a lot of information under hospice, and I want you to know that if you go out and you Google this, it's pretty, I don't want to say it's self-explanatory, but there's good information, and the timelines seem to follow with the other scenarios that the person is wanting information on. So one of the codes that you're going to get familiar with is G0337. Now this is a HCPCS code, Hospice Evaluation and Counseling Services Pre-Election, meaning that they're deciding that the person is going on hospice. That's probably the term that you'll be familiar with, or The hospice must obtain verbal and written certification. This is very important, all right, of the terminal illness. So hospice care, a person doesn't usually go on hospice until they know that they're at the end stages of life, and they're usually expecting life expectancy of 6 months. That's kind of a standard, is what they're thinking. Can it go longer? Absolutely it can go longer. Can it be less? Yes, it often is, but that's the time frame that they're looking at. They're looking at a possible 6-month window. So for that means the person has to be terminally ill, and no later than 2 calendar days do you have by the end of the 3rd day after the start of each benefit period, initial and subsequent, because mind you, you're going 6 months, but it could go longer. Initial certifications may be completed up to 15 days before hospice care is elected. That means that there's a lot of counseling that goes on here, and everybody rightly so wants to make sure that this is the best for their loved one. Now, going on hospice is really just helping the family. There's guidelines that are different for a person on hospice versus a person that's an inpatient even, or getting home health. The hospice nurses are able to do much more for a hospice patient than a home health nurse can. And a lot of that has to do with the comfort of the patient. They know in depth what the disease process is for this patient, and therefore it really is very helpful, not only for the patient and their comfort, but for the family members, because you can think of it as it just takes away the red tape. Okay. So the hospice election date, or the admission date when you start hospice, is January 1st, 2014, and the physician's certification date would be January 3rd, 2014. This is just a scenario. The hospice date for coverage and billing is January 1st of 2014. Okay, that's how that would work. The first hospice benefit period ends 90 days from January 1st, 2014. Now, like I was saying, they usually don't allow someone to go on hospice until they know they're about 6 months. They have about 6 months, and these certification periods go for 90 days. All right. A hospice representative must make sure the required physician certification and there's a physician certification and a signed hospice election statement, meaning the family or the patient has decided to go on hospice. And these have to be in the record before the signing of the form, the CMS 1450. All right. Now, I know a lot of you are familiar with the 1500 form, but hospice has their own billing form, and that's the CMS 1450. Okay. And it has, in this situation, nobody else does this, but a stamped signature is acceptable, meaning that the physician can use a stamp. This is, nobody else gets to do that anymore. Stamps are out when you deal with Medicare or Medicaid. Just a heads up with that. And that's why I added that, to let you know that the information that I was looking up, because I was shocked to see that a stamped signature was accepted for these forms. All right, so the hospice. Think in yourself, go. That's why I put the G and the O here. It's a 0. These are the code ranges that you're looking at. G0151 through G0164. Services delivered under an outpatient occupational therapy plan of care. All right? So now we're done with hospice and we're talking about occupational therapy. And this is going to work with physical therapy as well. There are specific codes for each of these. This was the best example I could find, so that's what I went with. The G0151, services performed by a qualified physician therapist in the home health or hospice setting each 15 minutes. Now, one thing that is different for therapies is that it is divided up in 15-minute segments. And if you're not used to looking at physical therapy notes or occupational therapy notes, they are a whole different ball game to what you're used to with nurses' notes and stuff. And I know a lot of people struggle with looking at them. If you have done home health, you'll be familiar with the way they look, but they do everything in 15-minute windows. And this can be very confusing when someone who's used to looking at nurses' notes goes in and says, I can't make, this is not a rhyme and reason to this. But that's why it is confusing. So then to G0164, skilled services as a licensed nurse, LPN or RN, in the training and or education of a patient or family member in the home health or hospice setting each 15 minutes. So, yes, the patient that is on hospice can still be getting occupational therapy, so that's good to know, isn't it? It's not like they say this is the end and we're just keeping you comfortable. No, they're doing much more than that. So again, these are the codes that you're going to be looking at. Now, I wanted to show you a range also of the hospice services. The following HCPCS codes will be used to report the type of service location for hospice services. And here's the definitions with them. I'm not going to read each one of those, but I want you to see that you've got hospice care is provided in all of these different settings. We have patient's home or residence, assisted living facility, you've got nursing, long-term care facility, and again, if you're not familiar, some of these sound like they would be the same, and they're not. They actually are quite different. We have a nursing facility, we have a skilled nursing facility, which we abbreviate as to SNF. We have an inpatient hospital, in-hospice facility. You have long-term care hospital. You have inpatient psychiatric facility and place not otherwise specified. And then last, it goes hospice, home care provided in a hospice facility. And you do see more of these, I think, even now than you used to find, is where they actually have a hospice facility and they're geared towards completely keeping that person comfortable and their quality of life as high as they possibly can get it till the end of life. And so you will find those places out there which are wonderful, and there's specific codes for them. Now, If care is rendered at multiple locations, each location is to be identified on the claim with a corresponding HCPCS code. So, see the codes that we did here? If one person moves from one to another, then you're going to change your code. For example, routine home care may be provided for a portion of the billing period in the patient's residence and another portion in an assisted living facility. In this case, reported one revenue code 651 line with HCPCS code Q5001. That's how that would be set up. And the number of days of routine home care provided in the residence and another revenue code 651 line with a HCPCS code Q5002 and the number of days of routine care provided in the assisted living facility. Now, really, it's just showing continuity of care, and there's codes to show that the person has moved. So again, we're just painting a picture, the best picture possible for not only the payer, but we're also dealing with statistical purposes, right? Don't forget that. Home health. These are the things that you're going to be dealing with in home health. The nurse is going to fill out what is called an oasis. This is like a 15 to 16 page document where an RN goes out and evaluates the patient and sees if they are a candidate for home health. Now, there is rules and guidelines that have to be followed. And for example, one of those would be that they can't drive. In other words, why would we be paying for a person to have a nurse come out to take care of the patient if the patient can't get to the doctor? And it has to be a very difficult and strenuous problem for them to be able to get to the doctor. It's not that they can't drive, but let's say there's a car and they have a wife, but we're talking about a gentleman here, but the wife is not comfortable driving in heavy traffic, or maybe the wife is working, or for whatever reason it's going to be very difficult for them to get the patient to the doctor and to specific visits that they need. And they need routine care. Maybe they have diabetes, they need their toes taken care of, or maybe they need their insulin injections, but they can't see very good anymore because of glaucoma, and they can't draw up their insulin or give it to themselves for whatever reason that the nurse needs to come and do this. So what they're going to do is the nurse will determine if they're a candidate for this, and any education or physical therapy that might be appropriate for the patient, or education. And then they'll fill out the oasis, and a plan of care will be created, and this plan of care is on a 485 form. That 485 form is sent to the physician, the patient's physician. The patient reviews it and states whether he agrees or wants to change anything on that plan of care for the patient. Right? So let's say that the patient is diabetic, and he wants to set the patient up on an insulin pump. So he would, in addition, add that he wants the nurse to provide education on an insulin pump for that patient. And so he would add that, and he would sign it. 30 days for an assessment and creation of a POC and to obtain a signature. So that's your time frame. So if the nurse goes out and fills out an oasis on January 1st, then they have 30 days to type up the plan of care, fill out the 485, get it to the doctor, have the doctor sign it, and have it back in the office. 30 days. There's a window there. 60 days of treatment for each plan of care. Just like the home health, there's a time frame. Theirs is 90 days. Well, each plan of care only lasts for 60 days. And so if the nurse knows that, our patient's not getting it, they're going to need some additional education. And then she's aware of maybe there's some occupational therapy that needs to be added to this for the patient. And so she would write out a new plan of care, a new oasis. They have to be reevaluated. The same thing starts over again every 60 days. They have 30 days to fill out the plan of care, the 485, get it to the doctor signs it, and gets back to the patient. And so everything is done on that 60-day window. Right? The CPT codes and the HCPCS codes, they're used for supplies. Okay, so again, there's a lot of supplies they're involved. If the patient is on insulin, the home health agency provides the syringes, and the alcohol swabs. All of that stuff is included in what the home health agency gets paid to take care of that patient. So there are some helpful codes. This is a cheat sheet for that. Let me just show you that real quick, and then we'll go back. This is a place that I found on CMS, Home Health Medicare Billing Code Sheet, and it just really has a breakdown of some of the codes. And here are those HCPCS codes that we had talked about, physical therapy and stuff like that. So you can find that on cms.gov. This particular one they copied over to cgsmedicare.com. That's cgsmedicare.com. All right, and again, this is a home health and hospice and stuff. Whole different ball game, completely different thought process. The general guidelines all apply, but they have their own unique setup for codes. And so it is I don't want to say it's a big business, that's not the right term, but there's a lot of need for coders out there that are savvy with this, because again, one person just as a general coder can't really just jump in and do this type of coding without a little extra education. There's going to be a learning curve on that.